This episode of the GeriPal podcast is sponsored by the UCSF Division of Palliative Medicine, an amazing group of palliative care clinicians doing amazing care.
UCSF Division of Palliative Medicine is dedicated to doing interdisciplinary work. They're dedicated to making a broad and inclusive environment for working. And we've had many of the members of the Division of Palliative Medicine on the GeriPal podcast, including Naomi Sachs, Danny Shamas, Cara Bischoff, Carly Zapata, Steve Pantelat, and Mike Rabo, among others. This is a terrific group of people, and I think you'd love to work with them.
And if you're interested in learning more about the position, please check out our show notes and click on the link. And best of all, if you take the job, you can hang out with me and Alex. What's better than that, Alex?
Nothing.
Welcome to the GeriPal podcast. I'm Eric Widera.
I'm Alex Smith.
And Alex, where are we today?
Today we are in Banff. We are at the Kathleen Foley Palliative Care Retreat and Research Symposium. Beautiful Banff.
Beautiful Banff. We've done some great hiking. We've listened to some great talks.
I did a painting class today. Painting.
And today we're going to do something that we tried out at CAPSI in Philly just not too long ago, which is we're going to mix up just a little bit about how we do the GeriPal podcast. So as usual, we've invited guests, but I love PBS. We're in Canada right now, but I love the fact that in the US, we do have this station called PBS, and they have this show in some locales, which is called Check Please. Anybody ever listen to Check Please? We got a Check Please.
Good.
Okay, we got a couple hands. Where they invite 3 guests to be on the show. And each guest picks their favorite restaurant. All 3 guests then go to the restaurant, eat a meal, come back, and they share their experiences, starting off with the first guest, like, why did you pick this restaurant? And then all the guests talk about their experiences with that restaurant. We're going to do the same, but with research studies or articles that we've invited 3 guests. They could pick any article that they want. They could pick their own. They could pick other articles. All of our guests then will read all 3 articles. We talk about why it's important. Why did they pick this article? And then we'll kind of hash it out together. Alex and I are going to be usually the hosts, but we're going to ask all of you to be the hosts too. So we have 2 microphones out there, so you can ask questions too. Importantly, the key thing is make sure your question ends with a question mark. So always should be a question.
It's like Jeopardy.
Yeah.
It's not a statement. It's a question.
It's a question to our 3 guests about the article. Why do they choose it? What's important about it? But do bring it in.
And you can include commentary, but you got to keep it brief.
Yeah.
Brief.
Because we only have about 15 minutes for each article.
Yeah.
And as usual, we're going to start off with a song. But before we do, we're going to introductions slightly different, Alex.
Yes.
Right, for introductions?
Yeah, we're going to ask our guests to introduce themselves to reduce complexity here. Prasanna, why don't you go first?
Hi, everybody. My name's Prasanna Ananth. I am a pediatric oncologist at Yale.
Great. And Dio?
Hi, folks. I'm Dio Kavalieratos. I'm a health services researcher and the division chief of palliative medicine at Emory University.
Great. Alexi?
Hi, I'm a medical GYN oncologist at Dana-Farber Cancer Institute and a health services researcher.
Terrific.
Okay.
Welcome.
Thanks for having us.
And then we always start off with song requests.
Prasanna.
Who has the song request? Prasanna?
So, about a month ago, Eric and Alex had told us that we should think about a song that reflected Canada, so Canadian singers. So I was thinking about my song choices. There are a lot of different songs to choose from. And about a month ago, my son came back from school and said, hey, in writing, we learned about irony. What is irony? So I spent a while fumbling through an explanation, and then I said, I know a really good song. So we are going to sing Ironic by Alanis Morissette.
That's great.
And notice the we. So
We.
Alex,
We.
what does the we mean?
We means everybody. So Eric's going to put the lyrics up here. When I told Sean Morrison we were going to do this song, last week or so, he was like so deeply disappointed. Sean's sitting here in the front row, and we didn't choose a different song by a number of fabulous Canadian singers. And we will do this one, and we're going to do it great. Everybody's going to sing along, sing it out. We practiced it a little bit last night for those of you who joined the sing-along. You won the lottery. You died the next day. It's a black fly in your Chardonnay. It's a death row pardon, 2 minutes too late. And isn't it ironic? Don't you think? A little too ironic. And yeah, I really do think it's like rain on your wedding day. It's a free ride when you've already paid. It's a good advice that you just didn't take. And who would have thought it figures? Well done. Heard you.
It's like rain on your wedding. That's not ironic, is that? Right. A black fly in your Chardonnay? Awesome. What'd you tell your was son or daughter?
Son.
Son, yeah. That's a hard one because there's debate over irony, whether or not this is truly irony in this song.
It's true.
But we're not talking about Alanis Morissette. Sean, is that why you're upset at Alanis Morissette? He acknowledges. Yeah. Not maybe this is irony. Well, we're not talking about that. We're talking about 3 articles. So we're going to start off with the first one. Why good palliative care clinicians get fired. We have 2 of the authors of this article published in JAMA in the audience. I'm wondering, why did you choose this article?
So a couple of months ago, I had been thinking for the purposes of my research about therapeutic alliance. What contributes to a robust therapeutic alliance? And by that, I really mean the relationship between a clinician or a clinician team and patients and families. And then conversely, what also contributes to fractures beneath the surface or irreparable damage to a therapeutic alliance. And it led me to reflect on a couple of instances in my own career, both in training and then as a faculty member, where I have been fired. And it was in this context that I came across this piece in JAMA, written by my colleagues and friends, Drs. Abby Rosenberg, Elliot Rabinowitz, and Bob Arnold. What really resonated with me, and I think resonates with many of us who practice clinically, is how it sheds the curtain on what could otherwise be a very isolating and lonely experience. So when I was first fired as a fellow in pediatric oncology training, it was incredibly embarrassing and I was very upset. However, I had this whole structure with a program director and, an associate program director, all of whom got on the phone and talked to me and walked me through this experience and then shared their own experiences, leaving me to feel a lot less alone. Fast forward a few years when I was fired as an attending, it felt much more embarrassing in many ways, and I did not have the courage to really share that experience with other people. And so what this piece talks about is why palliative care clinicians in particular might be especially susceptible to being fired. I'm not a palliative care clinician. I practice primary palliative care, but I am a practicing pediatric oncologist. And I still see so much in this piece that resonates with me. For example, they cite a number of studies that reflect on how patients favor clinicians who present a more optimistic outlook rather than realistic. And we're taught in our communication training to balance pragmatism and realism with optimism and hope. And so I think that we are all vulnerable to this, and we ought to be sharing more openly and being more vulnerable about our own experiences so that we don't feel so isolated and we don't feel burned out by these experiences.
Alexi, you're an oncologist. Did this resonate with you? Because the interesting thing is this was published in JAMA. This is not a specialty journal. But it's about a specialty care, palliative care clinicians getting fired, which surprised me that it got published, but it seemed to resonate with a lot of people. The comments were, like, if you go to the website, all of our listeners who are just listening will have links to our show notes, but you can go there, we'll have links to it, and you can see the amount of people that commented, which was impressive.
Yeah, I think that, like Prasanna, I'm an oncologist, and I have also been fired, and it's very isolating and lonely. and often cause me to reflect back on like, what could I have done differently, and I'm sure there are things that I could have done differently, but some of it is that you're often a harbinger of bad news, at least from the family's perspective. One thing that's been interesting to me is sometimes I've seen colleagues who are palliative care physicians who choose very optimistic oncologists or medical care teams, despite being well-trained in palliative care. And I'm wondering what you guys make of that.
Any thoughts?
Go for it. Go for it.
I mean, I'll take a stab at that instead of throwing you guys. I do think probably a lot of us have had a time to think about what we would want and are often very clear. I mean, you never know until you're in the situation, but sometimes have real clarity about what we would want and what compromises we're willing to make. And, for us, it may be doing everything possible, even if at times we've seen people suffer from that, or it may be otherwise. I guess that's the way that I've kind of come to terms with that, but others may have other ideas.
So I'll jump in here. Could we do a show of hands? If you're a clinician, please raise your hand and keep it up. If you haven't been fired, lower your hand. Okay. I would say like a third of the hands went down. Most of the hands stayed up. Thank you. I think this is really common. And it's common across. We have all sorts of people here in this audience at the Foley Retreat. We have people who are palliative care clinicians. We have geriatricians. We have pediatricians. We have people who are social workers. We have people who are nurses, nurse practitioners, people who are in cancer, people who are in geriatrics, all sorts of specialties. And it's just so common across specialties. I'll say, like, my own experience, like, I got fired a lot when I was a palliative care fellow. I mean, like, so it's kind of hard to say that, but it's true. And because I talked to my co-fellows who were great, like Kathy Silvaggi, Jane DeLima, like, like Juliet Jacobson. And they didn't get fired as often as I got fired. So I was like, what's going on here? What's happening? Why is this? And I think in my case, I drunk the wrong Kool-Aid. I drunk this Kool-Aid of like, I know better. Like these experiences, James Tulsky in his one of the opening talks was talking about this experience of coding patients in the hospital again and again. And the moral distress that causes. And I have to say, like, I felt that. And I felt like I was on a mission, like to help patients like understand what the dangers were of this. And I think I pushed too hard on trying to get them to know, to understand what I had learned. And that resulted in me being fired a number of times. And I think it's important to learn about this. So kudos to Abby and colleagues for writing this up and being brave enough to talk about it, and for Prasanna for bringing it up here and for talking about it today.
Well, I guess one question for you, Dio, as you think about this as a palliative care specialist, like they talk about this tightrope, this balance between we're doing like good palliative care providers are doing invitations to talk about these really hard things, about making sure there's safety involved in these discussions, but also that we go into the place of vulnerability. How do you think about that tightrope from your perspective as a palliative care provider?
First, I'm not a palliative care provider. Just to make sure. So I'm not over speaking here.
All right.
But as a scientist, I mean, yeah, go for it.
I think that, there's a line in the piece about if you, as a clinician, are never fired, maybe you're not being provocative enough. And then if you're
like
always
an appendectomy, like if you don't do enough appendectomies.
I think it's
that's my old school medical. Right. That was before they had imaging. Apparently, yeah.
And then the reverse is if you're always being fired, then you have to also reflect.
She looks at me. Yeah.
Well, I guess the other question I have is the quote, our job is not to be liked. It's to advance the conversation and advance the care.
Yeah.
It was something like that. I may have misquoted that, but in general, that was the theme. What do you think about that?
Yeah, I think that's really important. I mean, I think you have to hear the people that you're talking with. Yeah. But I think this concept that social desirability can be very addictive, but when you're actually putting the patient, in front of you, I think you absolutely have to, try to hear them, but it's not to be liked at the end of the day. It's to help them clarify their values.
But don't we want to be liked? I also think I have actually gotten fired by our referral teams, by surgeons and medicine teams. And my job is kind of to be liked by them because I need them to refer in the future to me for the good of our service, so that there is this balance, not even just emotionally. I kind of want people to like me, but I also need them to refer to me. And it is this delicate balance. What do you think about that?
And as you're thinking about response to that, we'd also invite people to line up at the 2 microphones if you have a question. We didn't want to discourage questions. We want to hear from you. So please come up to the mic. And when we call on you, make sure you introduce yourself for our listeners. Any thoughts on what Eric's question, or should we get to our first question from the audience?
I mean, I think come work at the Farber because we need more palliative care people. I feel like there's a glut, meaning there's a glut of referrals and not enough workforce. So I guess I'm an oncologist, not a palliative care provider. So
have you ever fired a palliative care provider?
I mean,
No.
I haven't. No.
Yes, we have our first mic question.
Hi, I'm Kelly Michelson. I'm a PICU doctor from Chicago. I used to work with a chaplain who used to talk about how she would go to visit her patients or their families, and oftentimes it's related to the teenagers. She would go and see if they wanted anything, and they would kick her out, and they wanted nothing to do with her. And she used to talk about that as an important intervention in their process. And I'm curious if there's anything related to that applies here.
What do we think?
I mean, that's really interesting. I have to say, as an oncologist, pretty much every time I bring up palliative care, I cite Jennifer Temmel with my patients. And I say, there's clear evidence it doesn't extend to GYN cancers, but the people live longer and better when they get palliative care. And so I don't know if that per se relates, but I think there are these important markers along disease courses. And I guess I try to move away from thinking of palliative care as hospice. But it's interesting to think about a chaplain showing up in the room as, I guess I don't know, I guess I want to have deeper trail marks, than these subtleties. I don't know.
Okay, can I defend myself now? I get fired. I haven't been fired in a long time. I can't even remember the last time I've been fired. And I think that thank you. Do learn the hard way. From our mistakes, we learn. And I think it's because I focus more on listening and forming a relationship. Like deep listening and forming a relationship. Like that's the most important thing. Understanding, like getting to know them, is much more important that they know what I know. Yeah.
But I think the interesting thing of this article that impacted me was, even if you are the best, even if you're doing everything right, even if you're following like Vital Talk perfectly, you're listening, you are doing everything right, you still will get fired.
Yeah.
Right.
I'm probably not being fired enough now.
You're not challenging them enough, Alex, right? That was also a point of this article. Are we there also maybe to challenge, to move the conversation forward? What do you think about that?
I think so. In the circumstances that you were sharing, Eric, about surgery teams or other teams that might fire you, it's an opportunity to have a conversation about what went wrong or what could be done differently, what sort of triggered that firing. And so to have a broader professional discussion so that palliative care is more accepted in those particular care contexts.
Yeah.
Any questions from our audience about this? This is your last chance. Yes, please introduce yourself. We know who you are, but please introduce yourself.
Oh boy. I'm Ali John Zarabi. I'm from Atlanta. Thinking about patient-centered care and putting the patient and family first. Is it ever a good thing for the patient to fire us?
Oh. Good for, could you clarify? Good for who?
For them.
Well, I don't know. I mean, it might give them a sense of agency.
Yeah.
In my context, I take care of kids, and it's often not the kids. In my experience, it hasn't been the children who are firing us. It's their parents or their family members. And so it might be the one thing they can control in a circumstance that is, that they can't control anything else. And so you often find in pediatrics, parents whose children have serious illness will fixate on nutrition or different service providers because that's something they have some agency over.
Mm-hmm. I'll say that one thing I learned from Susan Block when I was in fellowship training, what a wonderful person to help me debrief this, and we wrote a piece about this way back when, is that maybe it's better they get mad at us than they get mad at their primary team. Like, we're the consultant, like they need to take it out on somebody, and that we can be an avenue for that, and we can hold that. We can process that.
Yeah.
I guess the one challenge there is, what if you're the primary palliative care provider?
Yeah.
Like, you're in a subspecialty and you're being fired.
Yeah, sorry, when I said we, I meant palliative care consultants. I should have clarified. Yeah, good point, Prasanna.
Yeah, and there's the argument around the short versus the long game. While in the short term, if you give hard prognostic information, satisfaction may decrease. But in the long term, we don't know what the outcomes as far as satisfaction is. And Tony Bach talked a little bit about this in another, I think we had him on a podcast. We talked a little bit about that. Any other thoughts on this article before we move on? Or any other questions from the audience? Okay, let's move on to our second article. Dio, I think you brought up this article, which is about economic case for palliative care globally.
Yeah.
Why did you choose this article?
Yeah, great question. So, I chose it for, I think, two reasons. One was a little selfish, right? So I study models of palliative care, and I've been guilty of having a very sort of US-centric frame of mind and thinking about models of palliative care. And so this was sort of a nice article, which comes from a larger WHO piece, thinking about palliative care globally. I think the second reason was, and I apologized last night to y'all that I was going to get a little political with this, so forgive me, but I think given the current times where we are in the US and thinking about health and social policy and investment, it makes me, I think it's a good reflection point to think about what is going on globally and how does that relate to what we have in this country. I think, many of us are really worried about cuts to reimbursement and access to care, as well as many of us are also worried about cuts to research funding. Both of those things, together, thinking about as well the privilege that we have in this country, that we have a really robust model of palliative care. If we quote CAPC data, for example, basically almost every large hospital in the country has palliative care services. 82% of hospitals with over 50 beds have palliative care services, versus what we see globally where most of the world does not have access to essential primary even palliative care. And so it was a nice reflection point to think about sort of where we are here and juxtapose that with where the rest of the world is.
I'm wondering from our other guests, did anything surprise you or catch your eye from this article?
I mean, I will say, and I forewarned you about this, I am astonished that basic pain relief is not available in other countries, and that it's even controversial to treat cancer pain with opioids sometimes in some settings. And there's a part of me that, kind of thinks about Paul Farmer, the late Paul Farmer, who said, it's not enough to give people substandard care. And there's a part of me that wonders, are we aiming too low if we're just going for kind of basic palliative care packages overseas?
I mean, I think that's a really fair point, right? And another reason why I chose this article and thinking about models of palliative care was it made me think about what are the essential components of palliative care? What is the essence of palliative care? And for example, from the article, they talk about essential palliative care packages, in a lower income country that costs, I believe it was $2.16 per capita, right? And so thinking about such an affordable model of care versus many of the sort of deluxe Cadillac interventions that we're thinking about in the US now, it seems like there's a contradiction there, perhaps. I think that there's a spot in the middle, right? I don't think anyone's talking about giving substandard care, but we are trying to reinforce access to care. And I think the other point, just to sort of, this might seem like a tangent, but I promise it'll connect at one point. But, I think the article also made me think about the inequities that we might face in this country given where policy is right now. And while I mentioned that we have privilege in this country of having palliative care accessible to most people in this country, I think a lot about historically disenfranchised populations, right? I think about cuts to Medicaid, for example. I think about decreased access for rural populations. And so just thinking about, what can we adopt from an article like this, and thinking about, again, what are the essential components of palliative care that all should get, and how do we scale those? Mm-hmm. Perhaps instead of thinking about super fancy, deluxe, technologically savvy models of care.
That's great. I think we have a question from Laura Hansen. Laura, if you could introduce yourself. Sorry.
Alex jumped the gun there.
You just know too many people. Laura Hansen from the University of North Carolina. This is such a powerful article to select, and thank you for doing so. I really wanted the panelists to really think carefully or talk about your perspective on the implications for populations that we fail to reach in the United States of America. There are so many of those populations. And I'm curious if you have any imagination that you can share with us from what you've seen in caring for those populations. How should we be changing our models?
I'm going to throw out something I learned from this article. Again, we'll have a link to this article on our show notes. But in Rwanda, they had they talked about this in this article, a tribal village where they elected community kind of health workers. So I'm not sure how much training they got, but they delivered palliative care in addition to other care to their village, which I thought was absolutely fascinating, but also made me think, Dio, like, how are we even defining this palliative care intervention? And is it a palliative care intervention? Mm-hmm. But that was like one model of bringing whatever this palliative care intervention was to the community.
And in the cancer care world, there are some studies, some trials in the United States employing lay health workers into rural communities to deliver bits and pieces of oncology care. So, that is a model that is tried and tested in various diseases and could be applied more broadly in terms of the delivery of palliative care.
So let me ask you a question, because this is a point of hot topic in palliative care. Like, what is palliative? Is it a philosophy of care? Is it a model of care? If it's a model of care, how much of palliative care needs to be involved? How many team members? What kind of dose? All of that. Like, when you think about that oncology, first, the community health worker that's going out, do you think that's an oncology intervention? Are you in oncology, are they struggling with the words like we struggle with it in palliative care?
What are your thoughts?
I know you're a PhD, but not a ton.
I'm going to go back to Dio. It's a great paper, 5 years ago in JAMA?
Almost 10.
I was almost 10? Holy smokes. It was like over a pandemic ago. Meta-analysis looking at palliative care interventions, which showed a lot of positive outcomes. Mm-hmm. But the question is, how are we defining what palliative care is? Because there was a lot of, you could have lumped or you could have split, but there was a lot of lumping of palliative care interventions that were not necessarily specialty palliative care. So I wonder how you thought about that, and how do you think about that in the context of this article?
Yeah, you're seeing me smile because I'm reflecting back 10 years ago, thinking about putting that article together and looking out and seeing some of the co-authors in the room and thinking, like, how much did we stress over that definition? It was really challenging, right? So what we did in that article was we used the National Consensus Project domains of palliative care, and we said that a study needed to comprise at least 2 of the 8 domains at that time of palliative care. Again, that was a tough decision. We chose 2 at least because we didn't want trials that or interventions that, just gave opioids for a symptom and that was it. We needed something more than that. But even that was a dicey definition, right? And I remember even we had back and forth in the comments after we were published of why wasn't this intervention covered? Why did you exclude that? We had to make decisions at a certain point, but I think it does bring back the point that I think is also resonates in this article that I chose, which is, again, like, what is that essential component? Is it communication? Is it symptom management? Is it goals? What is it that makes a palliative care intervention palliative care? I will also say I do think that we run the risk of having interventions define the entire field. And I worry a little bit about that because all of these interventions are different and they should achieve different purposes, more or less, depending on the population, the indication, and that point in that patient's disease trajectory at which we're intervening. So I think it's a complicated issue.
I'm going to push back a little bit because I struggled with this article because it talks a lot about the benefits of palliative care. Mm-hmm. It cites some of the people that we see here. Jennifer Tamel's article about the benefits of palliative care. That was a very specific palliative care model. Yep. That wasn't just philosophy of palliative care. Let's just see what happens when we do the philosophy of palliative care. It was a palliative care model that was implemented with like high fidelity. Do we run the risk when an article like this says, oh, look at all the benefits that palliative care does, and if we just implement any philosophy of palliative care, you're going to get those same benefits?
I think that's an implementation science issue, right? In many ways, right? So we study one thing, and then when we see it actually out in the real world, it's going to look different in a different healthcare system for a different population.
For a different country.
Exactly. And so I do think that we need more nuance in our discussion of palliative care. We can call, my personal opinion, it's a philosophy, and we have palliative interventions. They're all going to look a little different. But I worry about us, again, holding the entire specialty up to an RCT, for example. We don't see trials of nephrology care. We don't see trials of pediatrics, at least I'm not aware of. And so it seems a little bit unfair that we hold palliative care to that same standard.
I'll interject, and then we have 2 questions from our audience. What is palliative care, and whether something can be called an intervention, a service can be called palliative care, ought to be called palliative care? It's a question means like nothing, right? Because what we care about most is the patient's well-being, right? What happens to the people who have serious illness? And it means like everything at the same time. When we were at CAPC, there was great concern about palliative care light, and we have a couple podcasts that we're planning about that, which is, person goes out with a checklist of questions that they ask, patients with serious illness, and there is no follow-up, no feedback, and that's it. They've delivered palliative care, right? So the concern is, if that gets labeled palliative care, then we own that, right? All the bad outcomes too, and all the problems and complaints as well. So it means something is what this is really, we'll do many podcasts about this. Stephen.
Actually, she's first.
Okay, please, Marie. Oh, please introduce yourself.
Oh, thanks, Alex. I'm Marie Bakaitis. I'm here from the University of Alabama at Birmingham. Dio, I love the fact that you picked this article because of the idea of global attention. But I was a little perplexed. I haven't read the article. So about the economic benefits of investment in palliative care. And I'm glad that Diane is here and CAPC. And for many of us starting palliative care programs 1 billion years ago, one of the cases that we could make to convince our administrators was that palliative care could save money. And we could cite Sean's article, we could cite other people's articles to say that palliative care saved money. And then the light bulb came on to me and said, well, it doesn't always. Mm-hmm. And why are we trying to make the case for something about money when the case that really is about suffering and relief of suffering? And what is the price tag for suffering? So having not read the article, I'm just wondering is what the conclusions are in terms of economic benefits in the investment when we should really be caring about, my own personal opinion, about the quality of life benefits to investing in palliative care. So I'd love it if you could address that.
Yeah, no, that's a great question. And I fully agree with you, right? We should not hold palliative care just to sort of one outcome in particular, an economic outcome. I think what I took away from the article and the bottom line for me was that palliative care does not need to be some very complicated, fancy model of care that will be very expensive. It can be essential components. And that as well, that the article does not just talk about economic outcomes. It also talks about sort of the other outcomes that are important, like quality of life, like caregiver outcomes as well, too, from investing in palliative care. So I think it does a really nice job of balancing those and not just tying palliative care to economic outcomes.
Steve?
Stephen Connor, Worldwide Hospice Palliative Care Alliance. So it's ironic that we're one of the only fields in medicine that needs a definition, first of all. So we have to kind of reflect on that. To paraphrase Cicely Saunders, there's a lot of need for diversity in this field. Go out into your own circumstances and figure out how best to deliver palliative care. And I think that we have seen some really marvelous examples out of Kerala and a lot of other places of palliative care being done differently than we do it here in higher income countries with, pretty good outcomes, it seems. My question to you is, we have avoided the idea of asking WHO to create an international standard for palliative care. We've been a little bit afraid of that. But do you think it's a good idea, is the question.
I'm going to turn to our models of care person first. What do you think? International standards. We're going to also have Ira Byock on a podcast too, like thinking about should there be a minimum standard of care for palliative care in the United States? What do you think, Dio?
I think it's a really great question. I think it sort of depends on how it plays out, right? And what the standards look like. Is it competencies? Is it specific tasks? Is it, what? I think the devil's in the details. I do think that there probably needs to be a baseline so that you can say, I did deliver palliative care to this patient. I did that. But I do also agree that there will be a need for a lot of flexibility, recognizing differences in financing in each country, recognizing differences in culture and other factors that are important too. So I wouldn't want to see us over-standardize, because I do think then we lose the beauty of palliative care.
I mean, Prasanna, I'm going to turn to you as an oncologist. Like, you probably don't have debates over what is oncology. But the hard part is, like, there's no study saying, oncology saves money, economic impact. Like, but it also doesn't make any sense because, like, oncology is not the intervention that you're doing. It's usually about a type of drug or the model of care potentially in oncology. Like, if we're talking about evidence-based economic benefits, again, this article is just focused on economic benefits. They do acknowledge that is a side benefit, like that is not the main benefit. But don't we have to focus on like a specific model of care when we're talking about economic benefits rather than a philosophy of care?
Yes. And one of the challenges that I found in reading this article was that they were projecting a lot of data collected in the West on low and middle income countries. They were saying a lot about the costs of care in the last, weeks to months of life. All of those data are from the United States or from North America, not from low and middle income countries where I imagine a lot of people don't even make it to the hospital to die. So it is a policy piece. So it's not super expansive in scope. But that was one of the challenges that I found in reading this, that I felt like you can't translate that intervention or harness those data in a completely different setting where it might not be applicable.
So both the setting and the model.
Right.
We got another question from the audience. Please introduce yourself.
Tom Smith from Johns Hopkins for the past 14 years, but Virginia Commonwealth University and Medical College of Virginia for 28 years before that. And back before many of you were born, in 1988, 1989, a young oncologist and myself, Chris Desch, met with two advanced practice nurses, Cindy Simonson and Nancy Kane, who taught us to do a needs assessment, where you actually go in and ask people what they want. before you decide what you're going to provide. And so we looked at the map of Virginia where people were dying unnecessarily compared to the rest of the state of Virginia and the rest of the country. And it was all the rural areas, except central Richmond, which we couldn't help. But we went to those areas, and using my sort of business school background and engineering background, I thought we had to think really broadly about what we had to measure to make sure that this was going to be a valued component. So what we did was we went to each of these 5 different very rural hospitals, each at least 100 miles away. And we met with them usually at a Chinese restaurant and had dinner and asked them, well, what do you want? Then we want to have our surgery done here. We want our MRIs done here. We want our CT scans done here. We'd love to be able to do chemotherapy here. We'd love to be able to do good pain management here because we don't know anything about that. And we'd love to increase the use of hospice. Remember, this was back in 1988, 89. And so we set up a program where we would go like old Methodist circuit riders from one place to another, usually a pair of it at each place. And what we showed in the first 2 years was 700% increase in the use of morphine as pain management from 0. Pretty easy to go up from that. We showed going from 100% mastectomy to 30% mastectomy, and then 70% followed by radiation oncology, which is, as a breast oncologist, that's the best way to treat breast cancer. We showed for the local communities over 2 million miles of patient travel each year.
I think that's the really interesting thing, Tom, is that, and that's going to bring us to our next article, because I want to get to the next article before we run out of time, is that there are communities in the United States that are have very little access to palliative care, which we will talk about. I'm wondering in the last 10 seconds, any other thoughts, Tom?
We made a profit for each of the rural hospitals of $1 to $2 million a year by keeping their surgery ORs busy, their MRIs busy.
And that wasn't your primary goal?
Yeah, it was not. Palliative care was never about saving money. It was always about providing better care. But if you can do, as Diane Meyer says, mission alignment, and you can save money for the community, save miles of travel for the community, and teach people in the community to provide the right oncology and palliative care, it actually works. It's continued to this day. Every hospital in Virginia has a palliative care program.
Let me move on to our next one, because I think this connects really well. Alexi, this is your article, talking about a specific patient population where we don't have a lot of access to palliative care. Everybody in the audience, every listeners, just think about what population this is. Is it nursing homes? What is it, Alexi? What article did you pick?
Yeah, and I want to say this is my article, but it's really not my article. This is really an article that was spearheaded, ideated, created by Chris Manns, who's one of my mentees. And it's one of the reasons. So I chose this article for several reasons. One is I think we're in a period of time when a lot of marginalized populations maybe disappeared. And I see that in interventions that I'm doing where people who are undocumented are not showing up to get care. So we can't enroll them in the interventions because they're afraid of being sent and deported to other countries. But I also see this in places like, prisons.
And for our listeners, the article is Cancer Screening, Diagnosis, and Treatment of Vulnerable Patients in Incarcerated U.S. Prisons.
Yeah, so because of the particular political moment we're in, this feels very salient. But it's also a hopeful story in that I think a lot of what we've talked about today has been, people reflecting upon the way that their mentors give to them. And I got this grant and it enabled me to do this, and the mentors are what did it. But on the flip side of this this was not in an area that I was studying at all. I had definitely fangirled Bree Williams,
who's also,
I think the world of her and the work that she's, doing. I had taken care of a patient in particular who had ovarian cancer and, presented with a 30-centimeter mass in prison and got surgery from a gyn-onc and then had a wound dehiss and was essentially sent to a local hospital and shackled for the entire time that her wound was healing. And I had seen that personally. But I had not thought about studying this population until this mentee came to me and said, I really want to find out what's happening in prisons. And little did I know, actually, that cancer is the leading cause of death in prisons. And as we began to explore this together, interviewing, and he did the interviews, interviewing, lots of different PCPs and medical directors, palliative care physicians, oncologists who care for these patients, we learned that these things that we take for granted, like knowing when your next chemotherapy appointment will be. Well, it turns out if you're imprisoned, it's a security risk to let someone know when they're going to get their next cycle of chemotherapy, because they might actually, their family might help do a jailbreak. Having families present for fundamental family meetings, understanding that someone has cancer, is dying from cancer, this is also, they're excluded. And the fact that this is happening, in our country and in our systems was really eye-opening to me. And so that's, at this particular moment, why I chose that article.
I'm wondering from our other guests, is there anything surprised you about reading this article when you read it?
I was struck by the report from some of the physicians in the prisons who were saying that patients could only get supportive care medicines at certain times of the day. So they have to sort of present to the physician, 3 times a day. And so if they needed medication, they needed an antiemetic a little bit more frequently, they wouldn't have access to that. And they might not have access to opioids. In fact,
at all.
Didn't have access to opioids. Yeah, exactly. Just was really sobering.
Yeah, I mean, other pieces that definitely struck me too. I think, connecting it back to your article too, just making me think about delays in care and delays in communication and how that actually might play out with communication with oncologists, for example, or palliative care teams, not availing patients of that early opportunity for conversations and clarity about their diagnosis and their trajectory forward.
What stood out to you, Eric?
I think a couple things. First was, luckily, I work with a great interprofessional team, and they have to constantly remind me, which I should know. This is like Alex admitting something like getting fired too much. I often forget to include family members because I'm so focused on getting my work done, and I get reminded. Have we thought about who the family members are? The family members going to come? Are we talking to the family members every day? Because they're so integral to the care and the lives of our patients, and we are 100% relying on them once they're discharged, or once the patient loses capacity, and then we turn to them, but we've never included them before. I was shocked that they are really not included at all here. In many of these places, explicitly, they cannot be included in these discussions with their primary care doctor, their oncology team, because of security reasons. And that part shocked me.
Mm-hmm.
How do you deliver patient-centered care without including family?
Mm-hmm.
Yeah, and then I would add to that often security guards are present. So you're having this, reverse thing where there's an inherent power dynamic, where, this person is a security guard and you're asked to be vulnerable, without any family support to try to understand, and you can't get any privacy.
Yeah.
Mm-hmm.
What shocked you, Alex?
The use of correctional officers or security guards as intermediaries, right?
Yes.
They're the ones who can determine so many aspects of care, whether to report somebody's in pain, whether to, navigating whether they are able to consent, who's going to be shackled, all these sorts of things. Are they equipped to do that? These are huge, intractable issues. And there's so many other populations, as you were saying, Alexi, that this makes you think about. Like currently, speaking to today, people who are held by ICE, right? There's one of the Greenwall faculty scholars is interested in this. How ought we treat them and how can we work towards better care for those people? Before you take the question, I also want to plug our 2 prior podcasts. We did a podcast in prison with some terrific people who volunteer in the prison. We talked to the chaplain. We talked to many people, and Michelle DeThomas, who runs the palliative care program for palliative care and hospice in California. And also our podcast with Bree Williams and 2 formerly incarcerated people during COVID. Please introduce yourself.
Hi, I'm Judith Wags from Oregon Health and Science. And As I think about this, I think about the care providers in those situations. And, we didn't sign up to give bad care. And obviously this is bad care. So, and it's not just physicians, because a lot of the care that's delivered in prison is delivered by nurses or by nurse practitioners. So I wonder if that was considered at all when the paper was done.
I want to actually respond to that. I actually don't think that I think the system is incorrectly aligned. But one of the things that was striking about reading some of the transcripts of this and analyzing the data is these care providers often went to extreme lengths to try to care for patients, to make sure, for example, it turns out the only time in this country that healthcare is a right is actually when you're in prison. So, very ironically, some patients come to prison and haven't ever had healthcare. Thank you for coming. And then they get in prison and then they're released and they don't have healthcare again. And many of the oncologists we talked to or primary care doctors worked very, very, very hard to try to make sure that they were connected. So I actually think these were more, what struck me was there were incredible people struggling mightily against a system that was stacked against them.
So the care is really good, but the system is not designed.
I'm not saying the care is. How do you have really good care when you don't have family present?
But this kind of goes back to the last article about what is standard of care, and it depends a little bit on the systems, the models that we're working in.
Yeah.
And the providers that I know that work in these systems are very passionate, are very good. But I also see that we have an expert at the microphone.
Yes.
Bree Williams.
Yes.
Bree, could you introduce yourself briefly?
Bree Williams, professor of medicine at UCSF, and I direct the Aging Research and Criminal Justice Health Network, which is funded by the NIA. Thank you so much, Lexi, for including this article. It's timely, it's important. Just a couple things to remember. At our worst, 1 in 100 Americans were incarcerated, 100 American adults. That number has gone down precipitously over the last decade, but is actually going up if you count ICE facilities now. So a lot of people are incarcerated. What that means is 1 in 2 Americans have a loved one who's incarcerated or has been incarcerated recently. That is a staggering number. So this is really part of the fabric of the experience of being an American at this point. And so not understanding, not knowing what's happening inside these closed facilities is really a problem. I think one thing that you said, Eric, that I think is really important to underscore is this question about policies and procedures and what's allowed, that sometimes the families are not even allowed to be contacted. And what's important to remember, especially for those of us who might take care of a patient never in a prison, but actually in a community hospital where people go to get care, is that a lot of the policies and procedures that we are told are absolute are actually not absolute. And what some of the work that our team has done is actually look at the policies and procedures that are communicated to healthcare professionals inside and outside of prisons. And in fact, it's all like lore. It's like urban legend. It's not even true. If you look at the policy, if you look at the procedure, actually the policy says you should contact the family. And everybody has decided you're not supposed to contact the family. And so we actually, because it's such a part of the fabric of American society, it's very easy for us as Americans, I think, to just become correctional, to take on this assumption of what it means to be incarcerated and what it means to have limits around the care of people who are incarcerated. So I would just say that I think that this paper is really interesting because it's 32 healthcare professionals and their perspectives. And the next step is really to ask, how do perspectives misalign with actual reality? And remind ourselves to constantly question when you're told what the limits are and what is available and allowable, to say, is that really true or not?
That's great.
Thank you, Bree.
That's a great point, Bree. Thank you. I will say that there are 2 subsequent papers that will come out, one of which is looking at barriers and other strategies. And I think there's a lot of low-hanging fruit to solutions, but as usual, Bree, I hadn't thought of that one.
Well, Prasanna, Dio, Alexi, thank you for joining us on this GeriPal podcast. Before we end, Alex is having a moment, but he also is going to take a moment.
Okay, thank you. So I wanted to change it up for the closing song, and I had planned to play a song that Randy Curtis had requested for the GeriPal podcast, but I couldn't get through the song, much less talking about it without tearing up. So instead, maybe we could have a moment of silence for those who aren't with us today. Thank you. And now to joy. I encourage you all to read Danielle Free's terrific essay about joy. Joy through music is what she writes about. Playing Beethoven's Ninth. Joy as resistance. Joy as resistance. A great article. And so in that spirit, please join with me in singing this song. This song is dedicated to the Mick Jagger of palliative care, Sean Morrison. This first part is call and response, and then everybody join in after that. Can I kick it? Yes, you can. 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 I saw her today at the reception. A glass of wine in her hand. I knew she was gonna meet her connection. At her feet was her footloose man. Sing it with me. You can't always get what you want, yeah. You can't always get what you want, no. Say you can't always get what you want. But if you try sometimes, you might find you get what you need. You get what you need. You get what you need. Thank you. Thank you once again to our guests. Thank you to our listeners. Good night, Banff.
We'd like to say a quick thank you to everybody who's donated to the GeriPal podcast to support us in the continued work. And a shout out to everybody who's donated more than $250 in the last year, including
Mo Rizawi, Rochelle Bernacki, Daryl Owens, Mark Wren, Richard Lewis, John Bielenson, James Tulski, Elizabeth Cobbs, Christopher Heck, Meg Walhagen, Chris Jones, Kate Mesrich, Jen Hopping, Ashad Abid, Michael Bordowski, Asher Edwards, Susan Nelson, Harry Hahn, Carol Heyman, Gretchen Schwarzy, Sharon Brangman, Elizabeth Chung, Paul Amatelli, Brian Castle, Victoria Brond, Susan and John McFadden, Christopher Heck, Amish Moji, Matt Schuster, Carrie Hagan, Lloyd Woolstat, Carrie Levy, Marnie Fetzer, Ron Sabar, Stephanie Gabatuller, and Patrick Lally.
Thank you very much.